Thanks everyone. Thanks a lot for joining in on time. This is 2026 first Public Health Forum from Nivarna. For those of you who are here for the first time, Nivarna is a collective it's a volunteer run newsroom, I would say. Uh, Everybody who's working with us are doctors or health professionals, all on a volunteer basis. So what we do is tell public health stories on a digital format. We use articles and photo stories to talk about public health issues, to talk about last mile care, what is happening in the grassroots. We have used our platform to address various issues regarding health equity, such as how caste and gender and migration status, etc., affect people's access to health. We also provide medical students and junior doctors who are working in these areas to talk about their experiences as health workers. So that is something that we've been doing, which is has been really important, which is to give people who generally do not have a voice within the system to talk about their experiences. Now, public health fora are um, meetings which we organize where we call experts from various fields to talk about and to address any public health issue in a holistic manner. So we've been doing this for the past 2.5 years now. And I am Christianis. I'm the lead editor of Nivarna. I've been with Nivarna for about 2.5 years again. And my day job is that of an internal medicine doctor, but recently I have also branched out into journalism. So, with Nivarna and with this today's forum, what we're planning to do is talk about how, in the grassroots and practically how the TV program implications have been, and what paradigm shift we need to ensure that TB care reaches every last person who needs it. And our moderator, who will be conducting the rest of the session, is Dr. Swati. Dr. Swati Krishna, she is a public health physician and researcher who's primarily interested in TB. She was the former national consultant in NTEP in the Central TB Division. She is also a fellow of India Health Policy and Systems Research. Currently, she works as an assistant professor in community medicine at Bharati Vidyapeeth Medical College in Pune. She is also executing her HPSR project in TB care policies among industrial laborers. She is also one of our advisory board members here at Nivarna. So we go back a long way. So now I'll just be handing over the floor to Swati to introduce our speakers and moderate the rest of the session. Over to you, Swati.
Thank you, Christianes. Thank you so much. I hope I'm audible. Yes, so apologies, my device crashed in the last minute and I'm currently doing it from my phone. So, yeah, please excuse me for the display problems. So, this has been a tradition for Nivarna to conduct a public health forum discussion prior to World TB Day every year. So usually our discussion is centered around key messages from the WHO Global TB Report and the India TB Report of National TB Elimination Program. And we carefully curate a panel of experts and give our audience a real taste of the scenario of TB care and the challenges and the way ahead in our country. So this time we just have our global TB report in hand. The India TB report has not yet been released for the year 2025. So just to set context, we will discuss few key messages from the WHO Global TB report. Let me just share my screen. I have few slides just to set the context, and then we'll move on to our speakers. Christianis, could you please tell me whether you can see the screen?
Yes, Swati, I can see the screen.
Yeah, I'm sorry, I can't put it in slideshow mode. This is what I can manage. So, why are we still talking about TB? TB is the leading infectious killer. It kills, I mean, latest data shows that 1.23 million deaths were due to TB. So, it is the single most infectious killer after COVID. When the pandemic was on, it is back again as the leading killer. And of course, TB incidence and deaths have been declining. It is showing a promising trend that way, but still we haven't reached the committed targets. So what had the world committed for? So the world, through the sustainable development goals, most of the nations are signatory to sustainable development goals. In terms of tuberculosis, TB control, we had pledged to reach a 50% reduction in TB incidence, which is the new cases of TB, by the year 2025. But we have reached only a 12% reduction. And we had pledged a 75% reduction in TB deaths, and we have reached only a 29% reduction. And still, more than 50% of the TB affected households suffer from catastrophic cause. And if you see the burden of TB across the world, 67% of all estimated incident cases worldwide are from 8 countries, and India has been consistently topping the list. And as you can see, 25% of world's TB cases are from India. And in 2025, we also saw another human-made catastrophe, that was the fund cutting from United States and some other countries as well for various developmental projects. And the key areas of TB care which were affected, as you can see from the graph, were community engagement, TB preventive treatment, and community screening, patient support activities. Thankfully, India's treatment diagnosis pathways relied mainly on domestic funding. So those domains were not much affected, but of course, the community engagement initiatives, etc., which are relying heavily on donor projects, have had a setback. So this was probably a wake-up call for the global South to reimagine our care ecosystem for TB, on how much we should rely on donor funding and how we should make it more sustainable. So, what India has pledged to achieve by the year 2025 was the SDG targets set for 2030. India had pledged that we would achieve it on an accelerated timeline, that is 90% reduction in TB deaths, 80% reduction in TB incidents, and zero catastrophic cost affected families. So this would require at least 11% decline in the annual TB incidence rate, but we are currently at a 6% decline only. We have our current incidence rate of TB in India stands at 187 per lakh population. So we must be very careful when we say that. Quite vaguely, we have heard so many people say that India is about to eliminate TB, or India is supposed to eliminate TB, eradicate TB even. So this is what the epidemiological indicator we are referring to is. We currently stand at 187 per lakh population. So with this context in mind, let us move over to the discussion of today. And let me introduce our speakers one by one. Let's move on to our first speaker, Meera Yadav. So Meera is a TB activist, member of a community-based organization called TB Survivors Collective, and an XDR TB survivor herself. So, Meera, 2025 was supposed to be the magical year for India, wherein India aimed to attain the 2030 SDG TB targets. Recovering from the setbacks due to the pandemic and amid some positive trends, we still have a long way to go. What are the burning issues of the community and what needs to be done more? Over to you, Meera.
Thank you, Swati. Thank you, Swati, and thanks to Nirvana's team to organize and set up this panel discussions. Uh, uh, as a survivor, that I have to highlight some major areas. Like there are in the ground level, many challenges are there, but some of like key burning issues and the most important barriers that I need to highlight here, and I have to raise this here. So first is like as a survivor and through my lived experience or field experience, what I have faced it, and still there are the challengeable like delayed in diagnosis. We are in 2026 and we have a tools or technologies like we have a CBNet machines or TrueNet machines, but still there are like in some rural areas or semi-urban areas, especially whereas limited resource settings infrastructure. So there is maybe some of areas they have the machines, but what about the cartridges? So CBNet machines, and so this can becomes like delayed in diagnosis and treatment. Timely treatment is also very equally important. Cases like me, I was wrongly diagnosed, but so the delayed diagnosis. So it is also very important to address this. And the second is following to this, like extrapulmonary TB diagnosis, and still like government they are provided the services like free medicines and test. But what about the diagnosis of EPTB? Still there are the challengeable, like in many health centers or labs, they don't have FNSC, they provide FNSC test or biopsy test. So still there are the challengeable, like patients go to the dot centers or health centers, so they can if refer the test. So what they will refer when they will refer to the प्राइवेट लैब, एंड इसमें होगा क्या कि पेशेंट्स को अपने जेब से पैसे डालने पड़ेंगे. तो इट ऑल्सो अकर्स लाइक आउट ऑफ पॉकेट एक्सपेंडिचर बिकॉज स्टिल अभी तक हमारे पास में एफएनएससी के डायग्नोसिस नहीं हो रहे हैं. और ये सारे टेस्ट जो है जिससे एक्स्ट्रा पल्मोनरी हो, और इसकी वजह से डायग्नोसिस डिले हो सकता है और पेशेंट्स को गलत ट्रीटमेंट मिल सकता है. एंड वी हैव सम सर्वाइवर्स दोज हु फेस्ड इट. तो यहाँ पे दैट वी नीड टू इंश्योर कि प्राइवेट हेल्थ प्रैक्टिशनर्स को भी दे मस्ट बी ट्रेन इन उनकी भी ट्रेनिंग इंपॉर्टेंट है, ताकि वो टीबी की जांच को जल्दी से जल्दी अगर उनके पास में ऐसे कोई सिम्टम्स आते हैं. हालांकि देयर आर ऑल्सो चैलेंज कि ईपीटीबी का जो सिम्टम्स है वो जल्दी नजर नहीं आता, बट लेकिन जहां पे भी उनको लगे थोड़ा बहुत भी, तो वहां पे तुरंत वो टीबी का टेस्ट कराएं ताकि पता चल सके कि इन्हें टीबी है, एंड दे कैन स्टार्ट द ट्रीटमेंट और दे कैन इनिशिएट द ट्रीटमेंट. तो एंड देन सेकेंड इसके बाद में ये है कि डायरेक्ट बेनिफिट ट्रांसफर. Like if I would talk about DB Tika, earlier it was given 500 rupees a month, and now they increased up to 1,000 rupees. But country like India that we have a face, and every year inflation is increasing up to 5%. So if I calculate like 1,000 patients are getting 1,000 rupees per month, so एक दिन के हिसाब से it comes around 30 to 33%, which is we all knows that is that enough to get basic foods or healthy foods. DBT, what government said ki these are the this 1,000 rupees providing as an additional support for a nutrition support, but 1,000 rupees still not enough. So here also as a survivor or patient perspective that we need to advocate here, they should be provided at least 2,000 to 3,000, ताकि उन्हें एक महीने के हिसाब से एक बेसिक फूड मिल सके. बिकॉज न्यूट्रिशन इज वेरी इंपॉर्टेंट. व्हेन वी टॉक अबाउट टीबी इट्स डायरेक्टली कनेक्टेड टू द न्यूट्रिशन, क्योंकि हमारे दिमाग में यही आता है कि वो डायरेक्टली असर करता है इम्यून सिस्टम पे. एंड स्पेशली if I will talk about marginalized groups or migrant workers or laborers, so maybe some of they are not financially stable or financially strong. So how they can get a nutrition foods or basic food at least. So इस चीज को ध्यान में रखते हुए that we need to raise these issues here कि at least उन्हें मिले. And the problem is that कि 1,000 रुपीज जो मिल भी रहे हैं वो टाइम पे नहीं मिलते हैं. यहाँ पे ये सबसे बड़ा ये है कि अगर लाइक पेशेंट्स मेरा ट्रीटमेंट स्टार्ट होता है, इफ आई स्टार्ट माय ट्रीटमेंट टुडे और डीबीटी बैंक डिटेल्स वगैरह फिल करने के बाद में मे बी 1 वीक और 2 वीक, सो एज पर द पॉलिसीज ऐसी ऐसी है कि हाँ ये न्यूट्रिशन के लिए मिल रहा है तो हमें विद इन अ मंथ पेशेंट शुड बी रिसीव. बट ये मिलता कब है? मे बी 3 months लेटर और 4 months लेटर. और यहाँ तक कि देर आर मेनी केसेस कि दोज हु गॉट इट आफ्टर कंप्लीशन ऑफ ट्रीटमेंट. So these are the small things, but we need to address here कि whatever we provided as a free of services or additional benefit, जो भी amount है whatever it may be, but they should get on time ताकि वो उसका लाभ तो एटलीस्ट ले सकें. 1,000 रुपीज no matter, but time पे मिला तो they can utilize at least. So these are the things, DBT, and the next is the major and most important psychosocial component. What we have went through with it as a survivor, like stigma. Stigma is still there. आज भी टीबी मरीजों के साथ में भेदभाव होते हैं और स्टिग्मा की वजह से उन्हें काफी कुछ खोना पड़ता है. तो स्टिग्मा को एड्रेस करने के लिए दैट वी नीड टू रेज हियर द अवेयरनेस. एंड यहाँ पे टीबी सर्वाइवर्स दे कैन प्ले अ वेरी इंपॉर्टेंट रोल टू स्प्रेडिंग द अवेयरनेस, टू प्रोवाइडिंग द टीबी सेंसिटाइजेशन सेशंस. तो साइकोसोशल कंपोनेंट की अगर मैं बात करूं तो इन गवर्नमेंट, इन आर पब्लिक हेल्थ सिस्टम्स, देयर इज नो साइकोसोशल कंपोनेंट. सो सर्वाइवर मस्ट बी इंक्लूडेड हियर फॉर्मली. यहाँ पे सर्वाइवर्स कैन लाइक दे कैन हेल्प एंड दे कैन थ्रू their own experience or they can share their lived experience. So यहाँ पे survivor can help bridge the gap between patients to the health system. They can carry patient voices to the health systems. तो यहाँ पे community engagement is very important. Survivors can also become a decision maker. And they should be included in program implementation, new research, policy. They should be included because they can also support them to provide the solutions. एंड लाइक हम बातें करते हैं कि टीबी हारेगा देश जीतेगा एंड टीबी, तो अगर इन सब छोटी छोटी चीजों को अगर इफ वी कांट स्टैंड, देन हमने अगर एक पैथवे नहीं बनाया तो ये सिर्फ बातें एक नारा बन के रह जाएगी. सो वी नीड टू एड्रेस हियर. हम कुछ नया नहीं मांग रहे हैं. एज अ सर्वाइवर व्हाट आई हैव फेस्ड इट कि जो चीजें हैं हमारी गाइडलाइंस में वो हमें टाइम पे मिले. लाइक ड्रग स्टॉक आउट एवरी ईयर, लाइक इंडिया हमेशा हर साल हम ड्रग स्टॉक आउट फेस करते हैं. इफ आई वुड टॉक अबाउट डीएसटीबी और वेदर डीआरटीबी, डीएसटीबी में आई स्टिल नोज ओवरऑल माई एक्सपीरियंस लाइक इन डीएसटीबी में इवन द फार्मा पर्सन ऑल्सो, जब भी हम जाते हैं मेडिसिन के लिए तो वो कहते हैं कि प्लीज डोंट मिस योर इवन ए सिंगल डेज का डोज. आप एक भी दिन का डोज मिस मत कीजिए, नहीं तो आपको यू हैव टू स्टार्ट योर ट्रीटमेंट फ्रॉम डे 1. दैट मीन्स कि दे आर रिकमेंडिंग, दे आर सजेस्टिंग देम कि एक दिन की भी दवा मिस करना इट्स वेरी डेंजर बिकॉज टीबी बैक्टीरियाज आर मल्टीप्लाइंग बाय डे और इफ वी कांट गेट अ ट्रीटमेंट प्रॉपरली. तो जब डीएसटीबी में ये बातें बोली जाती हैं, इवन फार्मा पर्सन्स बोलते हैं, तो अगर हम एमडीआर की बात करें और एक्सडीआर की बात करें तो क्या सिचुएशंस हो सकती है. एमडीआर में व्हेन ट्रीटमेंट लाइक 18 to 24 months का और इतनी खतरनाक दवाइयां होती हैं और वहां पे वो दवाइयां भी अगर हम टाइम पे पेशेंट्स को ना दें तो पेशेंट्स कितना रेजिस्टेंट डेवलप कर सकता है. सो हेयर दैट वी नीड टू थिंक हेयर कि हम कैसे इन चीजों को एक चीज पे लेकर आए और पेशेंट्स को, वेदर पेशेंट्स हैव अ डीएसटीबी or DRTB, MDR or XDR, patient should get treatment on time and with the right diagnosis. Because wrongly diagnosis is also can become a patient's lost his life or her life. So timely treatment and diagnosis is very, very important. And yes, still, like, as a community, we also need to demand that this is not a privilege. This is our health rights. We need to include in them. We need to include in the systems.
Right. I agree to every word spoken by you, Meera, like the timeliness of payment. We see here, like I work with certain set of persons with TB in Maharashtra here. So the timeliness of payment is a huge issue. There is a huge backlog. Many people have not got their DBT for months. Of course, Dr. Hemant's paper is there on the delay in disbursal of DBT benefits. I remember reading that it still keeps happening. And this whole issue of psychosocial support. But I guess right now, through My Bharat Volunteers, government is trying to include psychosocial support as well as part of one of the activities of Nikshay Mitra. We don't know how much it will roll out or like get implemented properly. I can see Catherine in the meeting. We'll speak to her regarding this during the discussion session. Thank you so much, Meera, for your insights. Let us move to the next speaker. So, when policies are drafted in urban offices for the whole country, what is often quoted as all inclusive or people centric are mostly not so. What is perceived as rural in the policy parlance is often the peri urban areas where things more or less function and are available. But the reality of majority of India is not so. It is the hard to reach, no network zones where the majority of India lives and suffering happens. So we have with us Dr. Vidit Panchal, a community health physician with the Basic Health Services BHS and a member of People First, an organization working among people with TB. He works amongst the most vulnerable groups for TB and has rich experience serving in the remotest parts of the country. Now, with it, we often talk about vulnerable populations and access issues in rural areas. You have served on ground across multiple regions. Please share with us your experiences in dealing with persons with TB in these regions, which is dominated by inequities. Over to you, Vidit.
Yeah, thank you, Swati and others. And I actually just have a few pictures. Just give me a second. I'll just share. Um, can you guys see this? Okay. So actually, I've been a doctor for like 6 7 years, and I've mostly worked in Chhattisgarh and recently moved to Rajasthan like 1 year ago. And I can tell a little bit about what I see in southern part of Rajasthan here, where there are a lot of migrant workers, and people in Chhattisgarh where people work a lot on iron ore mines. And what some of my friends are also facing in other states like Orissa, Jharkhand, and West Bengal, and also some people who deal with homeless population in Delhi and other big cities. And with some striking unfortunate similarities, we also have some variations in what we are seeing. So what I'm going to just share today is a gist of all these things, and maybe we can discuss more later. But I will before going further, I'll just state here that TB for us is a political disease, uh, because whatever we are going to talk about today, whatever I'll talk about today, is ultimately going to boil down to the basic issues of food security, basic income, safe housing, safe employment, which are no way a biological or cannot be limited to a biological causation of diseases. Uh, but just from experience, seeing that as a physician, most of my days start with certain these kind of questions to my patients. So I'm used to seeing patients who come with very obvious symptoms of TB, cough, fever, weight loss, all sorts of work exhaustion, difficulty in breathing, maybe blood in sputum. But they have all had these symptoms for at least 4 to 6 months. So it's a very common question. Sometimes I also ask out of irritation, what were you doing, all this while when you were sick? And, I get some very common replies that, one of my other family member also died of TB, so I was busy taking care of that. If it is a woman, then she was anyway, putting her household before her own health, so she anyway comes late. And but there are also questions in certain population that I get, especially if somebody is a migrant worker and he's employed somewhere else in a city. So sometimes his employer will not let him go back to the clinic to take his medications or to get tested. So it is not until that person becomes really, really sick that he comes back home and visits the clinic. Uh, and that brings me to a second question. When I ask them that where did you first go to seek a care? So it's a commonsensical thing that first somebody would seek care in a nearby private clinic, which is obviously in a city. So then they don't uh, adjust their prices according to a migrant worker or somebody who's a homeless person or anybody who can't afford treatment. So it is very common to see that they spend a lot in the first 2 to 3 consultations. I have seen people with the bills of 10, 20, 25,000 for a disease which is apparently as easily diagnosable as TB. And very often, uh, like what I have seen from my experience here, particularly in South Rajasthan, that TB is a disease highly linked to the job that somebody is doing. Maybe like a lot of my patients in Rajasthan, they work in stone crushing industries. So we also get a lot of silicosis care patients, and tuberculosis and silicosis is a very common finding. It's a very common um, finding in our clinic as well, and often the outcome is not desirable. I mean, the mortality rates are still very high despite successful treatment. So it is important for us to know what are they doing. But there are also certain other jobs that we know from our experience are known to be hazardous and cause lung damage enough so that somebody also develops TB in future. Like a lot of young boys who come to our clinic who are working in kitchens and big rasois in all these big cities who are also migrant workers. And so first they get lung damage because of those oil fumes and all that smoke that is accumulated in the kitchen, and also in a place where they are living in a they usually live in a very crowded place with 10 or 20 other workers. So enough lung damage has already happened before they develop tuberculosis. So and all it is just because I see a lot of migrant workers and who are also mine workers, somewhere else, and sometimes homeless people who have come back to home or come back to their own villages, finding home, I should say. But these inconsistency in staying in one place also cause a lot of interruptions in treatment, which often lead to either extended treatment, which is difficult to track in a TB patient, and very often the outcome is not desirable. As Meera said, that delay in diagnosis is a very important factor in determining the outcome of TB in our area, especially if we have patients who are coming after 4 to 6 months of the first onset of the symptoms. Um, and we also try to do a rapid survey in some of the organizations who work in TB. So this is what we basically found. At least 6 months are spent before somebody first appears to a clinic, and not just our clinic, but any clinic. And in the first 2 to 3 consultations, they're spending at least 10 to 12 hours, 10 to 12,000 rupees, sometimes more actually, if somebody got admitted because of respiratory distress or any other comorbidities that were present in tuberculosis. But the sad part is that even the qualified doctors who may be private practitioners, even if they can identify TB, nobody guides them to a proper channel or to a proper center where they can get a free diagnosis, or they can get free drugs for tuberculosis. So despite spending a lot of money, which is anyway a challenge for them, like a lot of them still have to take loans or at least sell one of their assets, like one of the household things, or maybe one of their cattle or anything. They're still not getting the right diagnosis, or at least the right kind of drug regime that should be there for even for drug sensitive TB. I'm not even talking about MDR TB, which is anyway difficult to treat. But this is the case. This is the case with most of our patients with drug sensitive TB. So migrant workers, just because I've been dealing with a lot of migrant workers. So seasonal migration in them is a thing that itself causes a lot of interruptions in treatment, and it is very common to see somebody taking 2 months of anti-tubercular drug every year for 3 to 4 years and still not getting cured. I have a few patients who have also been on anti-tubercular drugs for over 12 months, and they are drug-sensitive tuberculosis patients, but the TB in them is just not getting cured because they would migrate out for 1 or 2 months for work as soon as they get a little better, but they will fall sick again and then again come back to home. Um, and migration is not just a problem with identity or being unsafe in a city where people don't know them. Um, it is also a very important factor in disintegrating families in our region. We know rural areas as in from movies that as these are places where people are so bonded together, people gel together really well, and it's very rosy, happy community. But it is not the case in our areas. Things like migration and low food reserve and and low employment opportunities not only makes young boys and sometimes even young women leave their home, but it disrupts the whole family structure, which we usually believe to be a strength in rural areas. So this lack of family support, which is a vital part of that vicious cycle of tuberculosis, is for me, I think is one of the biggest predictors of outcome in these areas. Because even if somebody falls sick in the city and comes back to his home thinking that okay, घर वाले मेरा ध्यान रखेंगे, but sometimes even family members are clueless because they're worse off without that person's income. So apart from all these factors like crowded workplaces or not getting CBNAT or sputum test close to where they're working, or having no health facilities in their industrial site or near the place of their working, is these are like obviously important issues, but you know uh, these long distances that they had to travel back to their home to get one simple diagnosis of tuberculosis, and still not getting enough family support, or again not being able to talk about it because of stigma in their community. These are the things that still impact health in these communities, particularly migrant workers. And so very often, a mine worker would also be a migrant worker, but mining itself is an occupation that causes enough lung damage before symptoms of TB develop. I see a lot of patients who, despite successful treatment of tuberculosis, or at least a 6 months course of anti-tubercular drug, still have to take drugs for respiratory conditions because they develop what we call as post-TB lung disease. And now it is very well documented that a lot of factors for post-TB lung disease are present much before then TB develops. So whether somebody recovers from TB or not is not the question. That person is on treatment for years and years, and it progressively debilitates the body, and the outcomes may be just as worse as they are in tuberculosis. And we actually never go out and find out what are the death rates in people who have completed the treatment of tuberculosis. There is no accounting for that in government health programs. No government or health officer is supposed to go and do a death audit for TB patients or even recovered patients in his or her area. So these are the deaths which are going undocumented and also unaccounted for. So yeah, these are actually the conditions in which some of our patients also work. Very unsafe employment. Sometimes the nature of work itself demands so much of hard labor. People go on fasting by like forcefully. There is a long gap between their two meals, and what they are eating also is not very nutritious. So it's not just it's so, at once they receive all these toxic exposures on their airways, which are anyway making them sick, but also not getting enough nutritional support at the work site as well as at home. With homelessness, there are some special issues that some of my friends have also reported. Like many of the homeless population, there is a very general trend of taking sporadic treatment for TB because in big cities where they are either staying in a shelter home or sometimes not even there, um, without an Aadhaar card, or without a legit mobile number, a lot of facilities will not register them as patients. Although Nikshay portal does not have a provision that if you don't have an Aadhaar card, you can't have an ID, but still it's a practice in many government centers that people will turn patients away, especially homeless people, if they don't have an Aadhaar card. So that's actually a gross injustice right at the point of care, which hardly gets talked about. So a lot of homeless patients either reach the facilities when they're very, very sick, can't work anymore, can't even, go out and walk for a while to find food and all. So a lot of our friends report that a lot of their TB patients die in the shelter homes, despite successful treatment. That's again a question of not just identity in a strange city, but also, like how inclusive our health system is. Sometimes somebody without an ID card is often denied care, even in big cities. I mean, we often see that in our rural areas as well. Meera talked about the Nikshay portal and Nikshay Poshan Yojana. A lot of my patients who don't have a bank account number, or at least don't remember their bank account number, or don't know how to access or how to withdraw money from a bank account, also cannot utilize that scheme for Nikshay Poshan. So it is true that often the money comes late, or sometimes even it comes when the person has died. But um, I have hardly seen somebody receiving money on time. With such large number of people being excluded from this kind of service, which is anyway not enough. This 1,000 rupees per person is given per person, not per family. We have to think that tuberculosis is a disease which is prevailing in the whole family. So a family of 6 member also get 1,000 rupees for nutritional support. A family of 12 member also get some sum of 1,000 rupees for nutritional support, and in my opinion, it just doesn't work. Women are, obviously they come until like they come to us when it is anyway too late. The good thing is that when they are more consistent, but there are several reasons within their household. They often prioritize the children health before their own health. And it is very common to see that at least 1 or 2 members of their family must already have been sick, either on treatment or recovering from TB, or died from TB, and then the women comes to us. So they've seen all these tragedies already in their home. And often, women in our clinics often do worse in terms of the baseline BMI, at the beginning of the treatment. So it is very common to see that the baseline BMI in our clinic, particularly in my clinic where I'm working right now, is less than 18. I mean, I think a few months ago we did a survey as well, and we found out that the mean BMI at baseline when we are starting treatment is 15.8, which is you know which is anyway a bad start. You can't expect a full recovery, or actually a true recovery in such a scenario. So what I'm left to do as a practitioner here in these areas sometimes is that I even a weight gain of 1 or 2 kgs during 6 months is good enough for me. Sometimes I see a weight gain of 5 kgs, and my face is lit up. Ki, okay, oh, बहुत अच्छा हो गया है तो, and this person did really well. Even if somebody's weight was 30 kgs at the beginning, and he was 35 at the end. So for us it's a victory. कि चलो इतना तो हुआ कम से कम. But these patients also require treatment which for more than 6 months. It's common that their X-rays are just as bad at the end of 6 months. So you often have to extend their treatment up to 9 months. And there are several comorbidities which exist with TB, like diabetes, HIV, or in our region, malaria is also a big problem, during which we have to interrupt the TB treatment. And there are actually no standard recommendations, no good literature to guide us like what to do in certain situations. Like everybody is trying to do whatever they feel best, but there is no standard guidelines, at least there is no new literature which can guide rural physicians on these areas. During the course of treatment, like I talked about having no Aadhaar card and no phone connection and all, which makes follow-up really difficult. But in patients with such low BMI, handling drug toxicity is one of the biggest challenges during the treatment, and also poor mental health. We have seen that either poor mental health can create conditions which predispose you to tuberculosis, or the reverse can also happen. But in either cases, there exists nothing which can address these issues in a very integrated manner. I mean, if you go to a government facility, at best they can say कि अच्छा इसको psychologist के पास भेज दो. but nobody sees ki this is a very integral issue for that person. You can't just fragment care at that level. So these are, and other issues like, having TB during pregnancy, and somebody not even recovering after 8 to 9 months of AKT. Well, these are some of the conditions in which, as a physician, I'm often clueless. Like, despite reading everything that's there in tuberculosis, I found very less literature to guide me, like, on what to do in certain situations. Like, what to do, like, how long should a patient with silicosis and tuberculosis take anti-cox treatment. So I often have to rely on my clinical judgment, which may or may not be, true. One of the major faults in, or major gaps in NTEPs, what I see is that there is absolutely nothing for the inpatient care. So, if somebody is really sick, like this is one of my patients from Chhattisgarh. He came to us during COVID, and he had completed his 9 months of anti-tubercular treatment. Came to us during COVID, where we were anyway overloaded. We had to refer that guy. Actually, he died on the way. So, also not on the way, but actually right after reaching the hospital. Why? Because the Ayushman doesn't cover the inpatient care for TB. They cover procedures, but not the whole inpatient admission and nutrition and other things for tuberculosis. So doctors either have to book patient under some other false diagnosis, which is often discouraged. So and even in Udaipur, where I'm working currently, there is nothing comprehensive for the inpatient support of TB, but it's an important aspect of care. Um, what I also see sadly on ground is that this elimination narrative has created a very bad internal pressure on the systems to just declare regions as TB free. So what I saw a couple of weeks ago, that there is a village called Nal, from where I received the worst of my TB patients in one of the clinics, and the government has put a board of TB free panchayat at the entrance of that village. But now what happens because of this enthusiastic declaration of TB Mukt Panchayat, whatever criteria they might have followed, or whatever they did to declare it TB free, but now when somebody comes with symptoms of tuberculosis, the health officers there are actually refusing them the test and the treatment, saying that okay, this is a TB free panchayat, we cannot afford having new cases because we have to maintain the status of TB free panchayat. So this is actually what we see with these new initiatives, which look so promising, look so bright, but the kind of pressure they are creating on these officials on ground, and this haste to just declare ourselves as TB free and whatever. This is to me, this is absolute nonsense. What we completely leave out of picture in rural areas sometimes, because of because pulmonary TB is so much on our face, is that there is nothing for extra pulmonary TB as well. It is so difficult even today for somebody with a TB spine, or a TB of intestine, who would often require prolonged treatment for for the recovery. The chain of referral is still as complex. The availability of drug is still as complex. There is no consensus on how timely one should get tested and all. So extrapulmonary TB in most cases are still treatment nightmare for us. And as Meera also talked about, there is no not just nutrition, but it is also nothing for psychosocial support for our patients, and let alone be accounting for the unsafe occupation and post TB lung disease, which for us is a disability. The person is dysfunctional once he develops post TB lung diseases. But I would just conclude by saying that TB, people take it as a marker of social progress and all those big talk. But what I believe as a physician is that it is a measure of the sense of community in the community. The more the way I have seen TB destroying families and destroying the solidarity that is there in community, the more it perpetuates itself. But in the national TB program, there is nothing which which would address TB at such a scale, which would actually bring people together around the issues of food, nutrition, housing, and not just food, but also addressing food security. So there is no mobilization of people around these issues, which would eventually lead to better outcomes in TB. So yeah, this is the gist of what I see on ground. Maybe we'll discuss some more in the last section.
Excellent points with it. Like, this is what is happening on ground. And in our forum on TB Mukt Panchayat, we actually discussed this as one of the risks of declaring panchayats as TB free, the false sense of protection that, oh, we are TB free. And like each group, you have nicely put out what happens on ground, and we feel we are much privileged when we get to hear all of that. Thank you so much. Now let's move on to our next speaker. We have with us Dr. Madhvi Bhargava, researcher of Rations Trial, professor of community medicine, and deputy head of Center for Nutrition Studies of Yenapoya University, Mangalore. She has been working for a long time generating evidence on the importance of adequate nutrition in persons with TB. So with its presentation also outlined the importance of looking at TB not only from a medical perspective, but from as a holistic perspective, especially with special stress on social determinants. So let's move on to Dr. Madhvi. Dr. Madhvi, addressing TB with a social lens rather than a mere medical lens is essential for sustained results. And undernutrition still continues to be the most important factor leading to adverse outcomes in persons with TB and for risk of contracting TB. Almost 7 to 8 lakh cases of TB in India are attributable to undernutrition. Now, the Rations trial in Jharkhand underlined the fact that food is indeed the vaccine, and it generated the much needed evidence required for policy change regarding nutritional support in TB care. And even the latest guidelines from WHO on TB and undernutrition were formulated with this trial results as one of the pieces of evidence. In the context of these guidelines, where does India stand and where do we want to be? Over to you, Dr. Madhvi.
Thanks. Good evening, everyone. Thanks, Swati, and thanks, Nivarana, for this wonderful opportunity. And thank you, Vidit and Meera. When you call me researcher, Swati, I am an accidental researcher because whatever Vidit said, I've experienced for 10 years and it takes me back to Chhattisgarh. And I'm an accidental researcher. So, for the outline of today's, what I want to talk about is that first, I'll give a broad outline of what TB nutrition guidelines have come out recently, and then talk about what is happening in India. And also locating it in the context of diagnostics and therapeutics, because as a person who has been talking about TB and nutrition, I'm actually very scared now of talking about nutrition when I hear about drug stockouts, lack of cartridges, and even sputum microscopy being abandoned in places. Something CBNet was supposed to be, point of care test, which has become more distant than microscope, which was closer to the people. So let me start with a broad summary. I do not have a PowerPoint, so I will be simply talking on these three broad aspects. So when we talk of TB nutrition guidelines, the last one came in 2013. Mind you, it is 2026 now. It came in 2025. So and the whole objective of these guidelines were one was to reduce the incidence of TB in those who are undernourished and coming from food insecure background. And the second was reducing undernutrition in patients with TB. So two important things. So two important populations we are talking about. So and before I go on there, I also would like to take this opportunity in the forum, this oft repeated question that I get, that why rations and why prove the obvious, you are being co-opted by the researchers. So 2013, and now it is 2025 and the guidelines come. And when there are 10 to 11 million people falling ill with TB every year, and 1.25 million people dying of TB in this age and time, whether, should we be stuck with this dilemma? Why should one prove the obvious and keep on doing observational studies and do advocacy, which we have been doing for all these years? And should we do that, basically the well-meaning group, why are you trying to prove the obvious? There's a well-meaning group which says that. And then there is another group which says, where is the evidence? We want to know the mechanistic models of why this is happening, why this is not happening. So observational studies led to this. That's why I say I'm an accidental researcher, because we just made a lot of observations, did a lot of advocacy to push this point. And we got funds to do this trial, where we started with the whole idea that at least we'll be reaching 2,800 families in the trial. It was not at all to create, the way COVID struck. It was more to reach those 2,800 families on time and save them from poverty, deaths, and hunger, rather than to publish in Lancet. So with that, I think I will proceed further. So two objectives of the WHO guidelines, which means that we are talking about two important populations and two important strategies. So when we talk of TB and undernutrition, I often see that people conflate TB care with TB prevention. Of course, they are related, but when it comes to strategies, we have to understand two things. What Ratios created in terms of evidence, and which was picked very enthusiastically by the global community, was TB prevention. And what we wanted was attention to the cohort of patients with tuberculosis, which for ethical reasons we cannot randomize and received the food basket all throughout. That was a cohort and could not contribute to the so-called grade assessment, assessment of assessment, development, and evaluation of recommendations, the grade guidelines. So, but of course, the modeling study, the qualitative study through this cohort, that definitely made a lot of impact on the guidelines, because you cannot generate evidence of a randomized control trial in patients with tuberculosis, where globally 1/3 may be attributable to undernutrition. So these are the two important take-home messages I feel this forum should take, that we are talking about TB care and TB prevention. What world is talking about a lot when it comes to ration is TB prevention. What I want as an Indian, where I see the burden so much of TB deaths, I also want equal attention for TB care, nutrition component of TB care. So that was one. And the other thing, when I say this, so 3 systematic reviews, let me be a little bit, I know Vidit has told a lot of stories and Hemant is going to talk about operational research. But before these guidelines got revised, there were 3 systematic reviews. This is more for the people who want to understand why, it takes so much time for new guidelines to come. So there's a process that is followed, which was also very foreign to me when I participated in the guideline development group as a resource person. So there were 3 systematic reviews that were commissioned by the WHO before the guidelines were revised. First was that in patients with tuberculosis, with or without undernutrition, whether good nutrition and or micronutrients, does it improve their mental and physical well-being and better outcomes? The second systematic review was that in patients with tuberculosis, with or without undernutrition, can micronutrients alone improve the outcomes? And the third one was among the household contacts of patients with tuberculosis, does nutrition intervention alone or with micronutrients, does it reduce the incidence of TB? So rations contributed to the third one and not the first and the second one. And probably it was one of the only trial, because otherwise, traditionally we are, TB researchers have been very fond of pills. So there are a lot of trials on micronutrients, including there was a trial on green tea extract, which can make your blood boil when you are in those meetings where people are discussing even that with equal rigor. So these were the three systematic reviews that were commissioned, and Rations contributed to the third one. And to summarize the guidelines, what new things in very briefly is that one, in the previous guideline, it was only moderate and severe undernutrition patients with tuberculosis who should receive assessment and support, nutrition support. But in the newer guidelines now, even the mild patients with mild undernutrition should receive assessment, counseling, and nutrition intervention. So that was one big change. And now in the guidelines, the household contacts have been added, where we give nutrition assessment, counseling, and support to the families with TB. So now, when we talk of these two strategies of nutrition care and nutrition for prevention for these two populations, one is vulnerable population who can develop TB, and one is already having TB. For India now, I'm coming to India specific situation. It's a very wide range where, Delhi can have more than, in Delhi slums or in some parts of Mumbai, it is more than 700 per 100,000 population, the incidence. And in Kerala, it is now downwards of 150 per 100,000 population. That is when it comes to geographical areas. Then there are subgroups. So where with it works, probably again it will be 700, 800 per 100,000 population. So that is where we are talking about the TB incidence. So people who are developing TB and who are vulnerable and contracting TB. The other thing is when we talk of the care aspect. So the mortality that we are seeing, for me, that is something which should be the first step. If I have limited resources, that we prevent the mortality. So that is something where I feel that maximum, whatever limited efforts we are having are right now directed towards. So with these things in mind, let us discuss what is happening in India currently. And when Vidit says that I'm happy even if there is 2 kg weight gain, and if somebody is 30 and becomes 35, I'm happy. The baselines with which we are working are very low. So when we did rations and when we first did the Chhattisgarh cohort, and we said that so many patients were undernourished, people said that, oh, it is Chhattisgarh. Oh, that is why it is like that. It is not everywhere. Right. And then the national figures came where, the median adult men were weighing, 47, and median women weights were 38 or something. So they were not very different from what we saw in Chhattisgarh, and that is in 2010. And fast forward to rations 2020, completed in 2022, things are no different. 80% had undernutrition, around 50% had severe undernutrition, moderate to severe undernutrition. So when we're talking of this kind of baselines, and when we want to prioritize groups, whether we want to give it to patients, whether we want to include the families, I think we need to think of the tuberculogenic environment from which people are coming. And the priority cannot be just, it cannot be, we cannot say, it's the inverse care law that works even in nutrition support, that people who need less are the ones who are, closer to the Nikshay Mitras. So let me first, before I come to Nikshay Mitra, let me talk about DBT. So it was 500 till late, and then it was increased to 1,000, and the first installment was improved. But imagine that in this assessment that was done by National Institute of Epidemiology, nationwide assessment that was done, 2/3 of those people who had unfavorable outcomes did not receive even one installment before their outcome was assessed. So we are dealing with that level of problem, right? That even before the outcome was assessed, the first installment was not received, and the median time that they received was more than 90 days, 3 months, more than 3 months. And rations, we have shown that the maximum mortality, and not just rations, anywhere, if you see the cohorts, whoever has done cohorts, they have seen that the maximum mortality is in first 2 months, the early TB deaths. So we are missing that biggest opportunity in the first 2 months when the delivery is being delayed. So that is one. And the second thing is that close to 90%, 87%, people said that this was insufficient. 500 was insufficient. So this led, and plus the cohort of rations was already published by that time. So there was a pressure on acting. So it was increased to 1,000 per month. And the first installment, it was said that we'll give 3,000. So that is increased. Let's see what the next assessment, when it comes. We don't know when, what is happening. So that is the first. So as per the website now, if you look at the website of CTD, it seems that more than 3,000 crores have been disbursed, and 1.13 crore beneficiaries have received some form of direct benefit transfer. The second initiative that we have is the Nikshaya Mitra. So Nikshaya Mitra could be anybody. It could be an individual, it could be MP, it could be a company, a CSR, local MLAs, corporate sectors, political parties. And minimum they should support is one person. So this is where I feel little disturbed. Because then the numbers which are there on the dashboard do not give us any information what is happening on the ground. That is one thing. And the second thing, inverse care law works. So, and then I'm sure there are a lot of, Hemant will talk about some of those operational research where there is no sense of equity. So it is like everybody receives at certain point. People who are severely undernourished or people who come from vulnerable backgrounds are not prioritized. It is just that it is being, and of course, there has been some streamlining of the basket. Initially, there were a lot of problems with the kind of basket that was being used. Some pictures were showing Bonvita and Horlicks, etc. So I think many of us raised some furor, and now that has been streamlined. I'm sorry. So that is the second initiative at national level. And the third initiative that I hear in terms of notification, but I don't know what is happening on the ground. As far as I know, it has not started yet. And that is the energy dense nutrition supplement. That was one of the smaller trials that was done during the same time as Rations trial. So they have done some analysis and they have shown. So first they did the acceptability analysis where it was some 90% acceptance with a lot of 11-12%, I think, vomiting and nausea, etc. And EDNS was supposed to be given to people who were undernourished for first 2 months. The problem with EDNS, according to me, and thankfully it has not taken off, maybe it will take off, is one that it is high in fat. It is very high in fat. So I just wrote down the components composition because I think it is important for everybody to know this. So it has 100 grams, it gives 540 kilocalories, which is good because you need extra calories. Proteins is 14 grams, but the fat is 31.3 grams. And it has high sodium, so almost 200 milligrams sodium. So there is a high solute load when you give it to the patients. and it can affect their physiology and renal function. So that is one aspect. But the other thing is that when we talk of energy dense nutrition supplement or any RUTF for that matter, it has a role in war zones. Definitely, it has a zone. Any natural calamity, RUTFs have a role because it is easier to. But why in community? We are actually mystifying nutrition. We are mystifying food. Already, people have changed from their indigenous diets to rice and wheat, and now we are mystifying it further. That if you have this packaged thing, then you are eating something nutritious. Otherwise, you are not. That is one. And even more worrying aspect of ADNS or any RUTF is that we are opening up space for industry to step in, which is finally going to increase our care cost. So that is my worry. And fortunately, as of now, it has not taken off. So these were the three things. But I can say that at state levels, there are a lot of initiatives going on. I think 2OR that Hemant has mentored, where they have started at least prioritizing those who are undernourished, and Kerala, for example, has a very varied food basket, and there are some other initiatives and trials that are being planned in some parts of India. So let's see. But why something is not happening in India? For me, let me tell you that I waited for 25 years. And post rations trials don't get published so fast. So for me, it's a dream run, trial getting published, receiving attention, finds a place in WHO guidelines. So as Indians, we are all very patient when it comes to policy change, and I feel that these are still few steps forward, and I'm ready to wait. The next part is that what is missing apart from one of the points that I saw in the chat box was that why money, why not food? So for me, anybody who has seen patients, I would not argue this or that. I would say this as well as that. That is one. We need everything. We need everything for somebody who is in that vulnerable phase of life. So everything is welcome. This or that debate is something we should not fall into that trap at all. So that was one. And the second thing, what is missing at the moment is that we are not having any great impact evaluation, whether it comes to Nikshay Mitra, even DBT. It was only assessment of disbursements. Outcome was not assessed, mind you. So we don't know how it has affected the outcomes in patients with tuberculosis. So we are not, we may be collecting height and weight, but we don't know BMIs in adult patients with tuberculosis at the moment at national level. So whenever a study comes out, people say, okay, this is an individual observation. Probably it's not happening in India. So one is that we don't have national level data on weights, connecting it to the outcomes, BMI, and what is happening in the outcome. And third is, if Nikshay Mitras is happening, and now according to the October notification, I think Nikshay Mitras can also support the families. Again, that is reflection of some reflection of the trial within India. So we do not have any impact assessment again for Nikshay Mitra or DBT in terms of care and outcomes. So what next? What should we be doing? One is documentation. Without that, no meaningful interpretation, and it's of no use. We'll continue to debate this even 10 years later. Younger people here who are attending will be talking about the same issues. So there has been no performance reviews. I think just like TB, diabetes, and HIV, Hemant and I had a chat before this meeting, and he very rightly said that why not quarterly reports having how much is undernutrition? If HIV and diabetes can be reported, why not undernutrition? And even in national reports, I don't think. And India is not the only country. No country is reporting BMI. No country no NTP is reporting BMI in patients with tuberculosis. Okay, so that is one. The second thing is, uh, you know, if I impact evaluation is one, but it is also important at individual level, what is happening so when we talk of nutrition, one is clinical care and the second is the public health impact. So even for the clinical care, we need to empower our primary care physicians, how to interpret what is happening in terms of weight gain, what is happening, what do you interpret if there is no weight gain. With so much diabetes, I think we need to start worrying about that as well. And of course, anemia is one. And how do we do this? I think it is not very difficult if we plan. One, I think we have DLHS reports, we have multidimensional poverty reports, we have NFHS. It's easy to map geographical areas. So although it's important to talk about some important subgroups, vulnerable groups like the Adivasis, the urban poor, I still feel that geographical demarcation and targeting is better because it will reduce exclusions. That is one. Another important subgroup, if we have to take a subgroup, is MDR. That is the first group that we should be right now talking about, where the family and the patient need to be included. And silicotuberculosis. That is, and again, how do you prevent? Because it's a family that is involved in a profession. It's never usually one person. So that was that. And finally, as I say, when I talk of nutrition, I'm very much aware of the drug stockouts. I'm very much aware of cartridges not available. I'm very much aware of even the program stuff, which is stretched to its limit, having so much of documentation. So it is political and economic question whether the enough budgeting is being done for all these activities, and whether should we just talk about, now AI has come, forget about CBNAT, now it is next generation sequencing, then it will be AI based. But where do we put the resources? We need to decide our research priorities. And with it, when you say that we don't have guidelines, you are the one who can create guidelines. You are the person best placed to create guidelines. I don't think WHO can tell you what you should do with people who come from such, bad tuberculogenic environments. What should we do? Because you are the one who will see this more often than anyone else, and not somebody sitting in Geneva. Thank you so much.
Thank you so much, Dr. Madhvi. Nutrition, all the points related to nutrition, and it is very shocking to learn that none of the countries report the number one morbidity for in terms of TB. And yeah, it is really shocking. So we'll come for discussion further, but for now, let's move to our next panelist, Dr. Hemant Deepak Shevade, Scientist E in the Division of Health Systems Research at ICMR, National Institute of Epidemiology, Chennai. Hemant is an operational research expert and has been one of the key persons behind the Tamil Nadu Kasinoi Irapilla Thittam, or TNKET, which is a statewide and state-specific differentiated TB care model to reduce TB deaths, implemented in the state from 2022 to 2025. This experience has contributed to the development of differentiated TB care guidance by India's National TB Elimination Program. So now a differentiated care model based on triaging of persons with TB at the time of diagnosis in order to reduce mortality is indeed a step towards providing better quality of TB care. How does this model operate across levels of the healthcare delivery system in our country? Please tell us about the Tamil Nadu experience. Based on these learnings, what challenges do you expect in implementing this differentiated TB care model across the country? Over to you, Dr. Hemant.
Thank you very much, Swati. Uh, So for me, the TNCAT story is very simple, and I've shared this on social media. Two people suggested a triage tool, and one lady in Tamil Nadu implemented it and scaled it up. And we happened to be present. ICMR happened to be present there. So basically, Madhavi and Anurag, they recommended a triage tool to assess severe illness, and that can be implemented in resource constrained settings because not all TB patients undergo. We would like that to happen, but not all TB patients undergo comprehensive assessment. And resource constrained settings, a triage tool will help identify the most severe as soon as possible after diagnosis and provide appropriate care for them, right? So basically what TNKET did is that it introduced 5 easy to measure triage variables as a part of baseline characteristics as a part of routine in the TB program of Tamil Nadu, which is body mass index, pedal edema, respiratory rate, oxygen saturation, and ability to stand without support. So I'll repeat: body mass index, pedal edema, respiratory rate, oxygen saturation, and ability to stand without support. By introducing these 5 triage variables as a part of baseline characteristics, the TB program staff, not just TB, I should not use that, the health system would identify those who are severely ill at diagnosis and immediately prioritize them for inpatient care. This is very simple, but how to do it at scale, and how to do it not at scale, plus also how to do it over a long term period, and how this contributes to TB death reduction. So this is the TNCAT story in short. So what I'll do is I'll break my presentation into 2 parts: the implementation part and how operational research contributed, how it guided the strategies under TNCAT. So for the implementation part, permit me to use, it is a last minute decision, Swati, permit me to use a slide set. I will then, shift to, interacting with those who are present here. So I'm sharing my screen.
Yes, visible.
Perfect. Yeah. So coming to reducing TB deaths, there are various ways to reduce TB deaths. And TNKET, which is basically differentiated TB care involving triaging for severe illness, is one of the many strategies. The general broad principle to reduce deaths is, even before detecting all, prevent TB. So you prevent TB from happening, so the deaths will reduce. Among then whatever TB is there in the community, detect all, detect them early, start appropriate treatment early, ensure adherence. Then the second general broad principle is detect and manage comorbidities. And the third broad principle is addressing social determinants, universal health coverage. And one of the multiple strategies is differentiated TB care to reduce TB deaths. Now, I'll introduce Tamil Nadu to all of you. Tamil Nadu is in the southern part of the country. It notifies around 0.1 million people with TB per year. And roughly 70% of deaths happen within the first 2 months. Madhvi was referring to this. The same is the situation in Tamil Nadu as well. These are called as early TB deaths. And, to end TB with focus on deaths, there was, so kudos to CTD that they actually came up with a guidance of differentiated TB care, which made the program and the health system think that we need to assess for severe illness and we need to provide inpatient care for those who are sick. But the initial guidance that was introduced in 2021 had around 16 indicators to be measured, which may not be feasible at most TB diagnostic facilities. And therefore, we decided that, we will introduce a triage tool, which we believed can be introduced in multiple across the state. Now, this triage tool that Madhvi and Anurag had already recommended in literature in 2020 was already assessed, or it was all the feasibility was already assessed before we started in Tamil Nadu. This happened in 16 districts in Gujarat and in 3 districts in 16 districts in Karnataka and 3 districts in Gujarat, where we use the window of opportunity of increased TB death rate during the COVID pandemic. We used it as a window of opportunity to push for triaging. So where in routine program settings we implemented this triage tool, and we found out that it is possible that you are able to achieve high coverage of triaging. You are able to measure all 5 variables, and you are able to achieve you are able to do this triaging within few days of diagnosis, because there's no fun in triaging by 10th day or 20th day, right? There is no fun that you're able to only collect one variable. So it was found that it was feasible. So we took this triage tool to Tamil Nadu, and Tamil Nadu said we are going to scale it up. And therefore, TNCAT started with the goal of at least 30% reduction in TB death rate. And this was based on previous feasibility assessments that we did. And we estimated that if this is implemented effectively, TB deaths can be reduced by at least 30%. So what's happening under TNCAT? So since April 2022, all adult public notified drug sensitive TB patients were triaged at diagnosis. We didn't include pediatric TB because, as per program guidelines, pediatric TB are referred to a nodal officer, a medical officer trained in pediatrics, or a pediatrician for appropriate care. So, if any inpatient care has to be done, it will be taken care of. For DRTB, all DRTB patients in Tamil Nadu or elsewhere as well undergo something called as pre-treatment evaluation. So therefore, other than generating the burden of severe illness, will not be having any operational benefit. Hence, this was a context-specific decision to focus on the elephant in the room, which is adult public notified drug-sensitive TB. And what we mean by drug-sensitive TB at diagnosis is those not known to have any drug resistance at diagnosis. And using the 5 variables, 3 conditions were assessed: a very severe undernutrition, respiratory insufficiency, or poor performance status. And if they had any one of these 3 conditions, they were referred, they are prioritized for referral, comprehensive clinical assessment, and inpatient care. Following the inpatient care, they were sent to the treatment facility or the treatment block or the treatment district to start on ambulatory dot. So a triage tool, a paper-based triage tool, was introduced in all around 2,800 public peripheral health institutes, starting from primary health center and above. And based on the 5 variables, there were 5 indicators. And using these 5 indicators, the health system was able to identify 3 conditions. And if any one of these 3 conditions was present, the adult with TB was prioritized for referral and inpatient care. We also introduced something called, if you look at the top, in addition to the triage tool, in the nodal inpatient care facilities, which were approximately 150 throughout the state, in the 150 nodal inpatient care facilities, around 600 to 900 beds were earmarked even before. It was done through a statewide mapping exercise. And there, once a triage positive will go, a triage positive means severely ill. That means any of one of these 3 conditions is present. We introduced again a 1-page case record form to ensure a basic minimum comprehensive assessment. We didn't want a person with TB to go there, get admitted, get IV line, saline, and come back, right? So to ensure basic minimum comprehensive assessment happens, and we are able to document their discharge outcomes. Then we introduced an inpatient care guide. This is, I don't know, this has not got that much attention, but we've developed a 70-page inpatient care guide. Now this is all available. I'll share the resources later so that this can be referred to for providing inpatient care. Then Tamil Nadu introduced severe TB web application, which was the e-tool of TNCAT, and ICMR NI designed this e-tool. So basically, key variables from the triage tool and the case record form, if the person with TB is severely ill, are entered in the severe TB web application, and based on the data entered, the process indicators are generated based on the numbers provided in the dashboard. Routinely, please note, this was an implementation project with a built-in ORIR component. The implementation and monitoring was part of the NTP activities of the state. And this was one of the conditions we discussed with the state, that this should be your baby. This should be treated as your baby. It will be implemented in routine health system settings. And the monitoring indicators will be part of the routine NTP monitoring. ICMR NI will provide lead technical support in co-designing that is planning, implementation, monitoring, supportive supervisory visits, and inpatient care. So basically, what we formed a technical support unit, basically involving permanent technical staff of ICMR and I, around 7 people, and some consultants and others, project staff who would join me from other projects. Basically, obviously, some other project will be going on, right? So this technical support unit, 4 to 5 were linked to the districts, and remaining 2 to 3 were linked to the state, and they provided technical support in planning, implementation, monitoring, supportive supervisory visits, and we also did operational research from time to time. So if you ask me who implemented TNCAT, I'm very clear about this. It's Tamil Nadu, the health system, all the 3 directorates, led by the state TB officer, led by the district TB officers, led by the NTP staff. They implemented TNCAT. So the monitoring indicators were introduced, which is 1997. Basically, to summarize, how many are getting triaged, of triaged, how many are severely ill, of severely ill, how many are getting referred, comprehensively assessed, of comprehensively assessed, once you confirm them as severely ill, how many are getting admitted, of admitted, how many are getting admitted for at least 7 days. So these process indicators were tracked. The hypothesis was that once the process indicators are met, that is, you expect a reduction in TB death rate. If you meet process indicators but do not achieve reduction in TB death rate, then one needs to look at quality of triaging and one needs to look at quality of inpatient care. For quality of triaging, the districts looked at burden of triage positive. Is it too low? So if it was low, it was assumed to be poor triage quality unless proved otherwise. And then we would also look at trend of triage positive across quarters. If there was a dip, are we able to explain that? If not, it is because of poor quality or a dip in quality of triaging. Then the most important thing is quality of inpatient care, because the NTP staff, the health system staff in the periphery, see, I believe as we go down in the hierarchy of, there's no there shouldn't be any hierarchy, but if you say hierarchy with respect to state, district, and block, the more you go to, more you go below, I can say confidently they are even more committed than me. The commitment increases. All they need is assurance. All they need is, if we do work, will the patient be taken care of? The problem is, if someone triages but appropriate inpatient care is not provided, then why would they triage correctly and show someone as severely ill? Because then they would be asked that you were not able to admit and so on. So it's very important to ensure quality of inpatient care, which requires isolation beds with therapeutic nutrition. Because what we found in Tamil Nadu is, out of 100 adults with TB, 15 were triage positive, that is, had one of those 3 conditions, and out of 15, 6 had very severe undernutrition. So people with adults with undernutrition, it is one entity that we just don't know, because none of us know the definition of cutoffs of BMI below 18. Everyone knows the cutoff of BMI more than 18.5. You know what is normal BMI, you know what is overweight, you know what is grade 1, grade 2, grade 3 obesity, morbid obesity. But less than 18.5, we do a blanket classification of undernutrition. But it's important to understand of undernutrition, how many are severely undernourished, BMI less than 16, how many are very severely undernourished. So very severely undernourished need therapeutic undernutrition. Severely undernourished 14 to 16 with poor appetite or any other complications also need therapeutic nutrition. If not, they will get discharged with poor appetite. It will be operation successful, but a person with the illness has, or with the condition, has died. So additionally, we also looked at proportion of severely ill with total score documented post comprehensive clinical assessment. So you have TB, people with TB triage positive. Of them, they reach the nodal inpatient care facility. How many undergo comprehensive assessment? The proxy indicator for that is for how many we have total score post comprehensive clinical assessment. Then we started also looking at 1 quarter and 2 quarter follow-up TB death rate, because if a district TB officer wants to look at whether I'm doing well, he cannot wait for 1 year, because TB program reports the official treatment outcomes, or should we say the program reported treatment outcomes are declared after 1 year. So it's too late. So we looked at 1 quarter and 2 quarter follow-up TB death rate for each quarter, and then we compared it with baseline, whether there is death reduction or not. So here you see me and Dr. Asha presenting TB death reduction by 20, early TB death reduction by 20% and overall TB death rate reduction by 10% within 2 quarters of implementation in July to September 2022 cohort. And this presentation was done in the Bali Union Conference in 2024. What we also wanted to look at is the sustained reduction, whether the reduction continues 1 year, 2 year, 3 years down the line. So basically, the data is your TB Seva data, which is the web application of TNCAT, and Nikshay data, because Nikshay provides you actually how many adults with TB are there and what happens to them. You have the data in TB Seva. Now, the justification for having TB Seva was that the variables that we are collecting, the 5 variables that I told, were not available in Nikshay. So therefore, we were justified enough to have a separate web application for the state of Tamil Nadu. Now, if you look at the care cascade, this is the care cascade for the year of 2024. What you see in yellow is the process indicators. So against 90, 90, 97 targets for the process indicators, the state in 2024 achieved 98, 93, 98, and 7. And you see around 12% were triage positive. I'm not showing the other details about the quality of triaging, quality of inpatient care, but working on the process indicators and working on quality of triaging and quality inpatient care, the take-home message is that though we had a lightning effect at state level within 2 quarters of implementation, it was not sustained. I'm sorry, you're not able to look at the last row because the last row has excellent. The last row at the bottom shows the state level. I've purposefully removed the names of the districts for confidentiality purposes. You can see as we proceed from left to right, you see more districts becoming green. That is the TB death rate reducing by at least 20 to 30%. I told about 1 quarter and 2 quarter follow-up when compared to baseline. And if you look at the baseline, Jan 2024 onwards, there was a sustained TB death reduction across quarterly diagnosis cohorts. And you can look at annual data also, that not only did the death rate reduce when compared to 2021, if I want to be devil's advocate, I can say 2021, the death rate was elevated because of COVID-19 pandemic associated, reduction in diagnosis or issues in treatment. But even before COVID-19 pandemic, the death rate was high, which is 6%. We have confirmed this through, confounder adjusted analysis. And we have also confirmed this through an interrupted time series that from 2024 onwards, after 2 years of implementation for a state like Tamil Nadu, we were able to achieve sustained TB death rate reduction. So broadly, even 3 years after implementation, because we're implementing a simple strategy, there is limited losses in the care cascade. 2/3 of the district in 2024 documented TB death rate reduction, and there was state level TB death rate reduction as well. What helped? Obviously, the process indicators, quality of triaging, and quality of inpatient care. This effect we have already confirmed through confounder adjusted analysis. So for those who are interested, we have all the material in public domain, the TNCAT videos, TNCAT tools and SOP. If you want to access all the paper-based tools, process indicator slides we used, therapeutic nutrition, how it was prepared, how did we track therapeutic nutrition during inpatient care. If you just access the TNCAT tools and SOP, with that 2-page document, you will be able to implement this kind of a differentiated TB care at the state. All the publications and lot of advocacy material is there. So those who are interested may please, go, scan these QR codes. I'll just pause for 10-20 seconds if you want to take a photo. I'm sure Swati will also share it later on over email, or you can write to me. I can also share this with you, or just follow us on ICMR NI's Twitter or LinkedIn handles. All these things are publicly available. So I'm going to stop, my presentation and just take few more minutes, Swati, about how operational research helped. I have 2 to 3 minutes.
Yes, sure. You can go ahead.
Okay. So, how operational research helped. First thing first, this triage tool was piloted in Karnataka and Gujarat before we went ahead in Tamil Nadu. If not in Tamil Nadu also, we would have had to pilot and see if that's feasible to implement or not. So that piloting helped, that it is possible to achieve high coverage of triaging, early triaging, and so on. Number two is that when we started with TNCAT, in 6 to 8 districts in the medical college for a period of 1 month, we implemented CTD's guidance of 16 indicators. We did that, करके देखते हैं, and we found out that patients diagnosed in medical college for a period of 1 month with full support, tracking and everything, only 60% underwent comprehensive assessment using 16 indicators, and now it has been increased to 20 indicators. So imagine if it is patients diagnosed in sub-district hospitals, primary health centers, and so on. And number two, using the criteria available, that total score more than 1, which was 2, 3, or 4, 60% of patients with TB were eligible for inpatient care. So in Tamil Nadu, to admit 15% of adults with TB, the process indicators I was talking, the second 90, that of those triage positive, how many get referred and undergo comprehensive assessment during inpatient care, was consistently 50%, 60% in the first 3 quarters of implementation. And after 1 year, through sustained efforts, we were able to achieve. Imagine other parts of the country. So why are we trying to admit 60% of TB patients? What happens is a person with a saturation of 90% will compete with a person with elevated LFT for inpatient care. I'm not saying an elevated LFT doesn't need inpatient care, but we need to address the most vulnerable first in programmatic settings. I'm very clear about this, and I think we're confusing public health guidance with clinical guidance. Right? Programs need to be clear. Are they issuing clinical guidance or are they issuing public health guidance? And we are continuously advocating with all the stakeholders that we need to implement a simple strategy. Coming to next operational research, other than routine MNE, we went and looked at what proportion of data that is entered in the TNCAT TB Seva regarding total score after comprehensive assessment is actually from case record form. Programmatically, there's always a pressure to put numbers, So this through operational research improved from 33% in the first 2 quarters to around 80 to 90% in 2023 and 2024. Triage audits were done, isolation beds were identified, therapeutic nutrition was, pushed for. So we also took support of, TB champions in 6 districts, that if someone is triage positive, they will get baseline counseling, and if they don't complete the care cascade, they'll get additional counseling, and it really worked, right? So this is how operational research work. And then by doing an impact analysis, which basically confirms the routine MNE, we have come to know that even for a state like Tamil Nadu, operational research shows that it requires 2 to 3 years of sustained efforts to bring down TB death rate, right? There's one final thing we have done. We have introduced a TB death prediction calculator. So what we have done with this is very, very simple. So in TB Seva, once we had 1 year, 2 year data with us, TB Seva is a data entry tool, right? We also introduced that if they enter data, they'll not only get whether the person is severely ill, but they'll also come to know the predicted probability. Based on past data, we generated a model and we put the model equation in the backend. So now the problem is that this calculator, which was introduced within TB Seva, cannot be accessed by other states because TB Seva is not introduced there. So we basically took out that model from from the TB Seva and we have put it out as a web-based calculator. And we have introduced other models as well, like TB death prediction just based on baseline characteristics that are captured in NICSHI. TB death prediction based on just triage variables, 5 triage variables. TB death prediction based on 5 triage variables plus easily obtainable baseline characteristics like age, gender. You will know whether it's previously treated. You will know whether it's bacteriologically confirmed. You will know whether it's pulmonary or extra pulmonary. You will know the test of diagnosis. You will know whether it is test of So all these things you will know. Other than diabetes, HIV, and bank account details, which actually take time. So what we found out is that TB death prediction using these 5 variables only. Let me repeat. So there's this Birbal ki story. How do you know someone's mother tongue? When someone is sleeping, you just put water on them. Throw water, 1 bucket full of water. the language they speak, whether it is favorable or unfavorable language, is their mother tongue. Similarly, I request you, you should know these 5 variables. It should become part of your mother tongue, like BMI, pedal edema, respiratory rate, oxygen saturation, ability to stand without support. These 5 variables were able to predict deaths as good as 13 baseline Nikshay characteristics combined. And the 13 baseline Nikshay characteristics are not available at diagnosis. It takes 3 weeks for this data to come. So therefore, we said that this also gives justification that why these 5 triage variables are required. ऐसे भी खाना खा सकते हैं वो जैसे Madhvi was telling ना, you need to generate more and more evidence to convince people, right? And in the end, what worked? And I'll end and rest I'll discuss while responding to the comments. What worked? Number one, triaging using a simple, this thing. We are just addressing the low hanging fruits. जो कर सकते हैं वो पहले करो, पहले चांद तक पहुंचेंगे फिर मार्स पे जाएंगे. So very simple. Beyond that, we told the districts अपनी अपनी भक्ति, अपनी अपनी श्रद्धा. Sorry if I'm using Hindi, but right.
It's
So, for example, some districts which had extra beds, they also admitted elderly. All elderly were admitted, irrespective of triage status, because all people who consumed alcohol, history of alcohol, were admitted based on their local data. But we didn't document that, because once you start documenting everything, then nothing will happen. So we said basic minimum, this has to be done, and against this, everyone can be followed and everyone can be compared also, right? That is number one. Number two, we monitored by diagnosis. Now, the whole TB program is monitored by current. So, this is a bit technical. So, you can generate cohort of TB patients by diagnosis. How many got diagnosed in my block? How many got diagnosed in my district? You can generate cohorts by how many are taking treatment in my block, how many are taking treatment in my district. So, this is called by current. So, the TB program monitors, which is for very good reason, monitors everything against current, right? But for this, because 70 to 80% deaths are happening within 2 months, half of them within 2 weeks, we monitored against diagnosed, right? Simple tool, using the diagnosed cohort as the baseline. Then leadership, believe me, when I go to the districts, I bow in front of the district TB officers. I'm not joking, and I speak. मैं उनको भी यही बोलता हूँ. Super committed district TB officers in Tamil Nadu. If you are depressed, so I use this strategy on a lighter note. Some Saturdays when my mood is not good, no, I'll just take my phone, call one DDTB, we call them DDTBs, district TB officers, one by one. उनसे बात करके मेरा mood अच्छा हो जाता है, because they are working in really resource constrained settings. So on a lighter note, committed staff, committed state TB cell. We had letters issued from all directorates, because differentiated TB care is not that TB program can implement. You want the health system to be part of it. Number three is isolation beds, not just TB beds. This took time. Now, though beds were earmarked, this took time. By 2023, 2024, isolation beds and availability of therapeutic nutrition. So these are the things, which help TNCAT. And I'm quite confident that, we should go ahead with this. Beyond that, we should leave it to local context, one-to-one clinical judgment, because ना पहले आपके हाथ बंधे थे, ना आज आपके हाथ बंधे हैं, ना कल आपके हाथ बंधे होंगे, right? For example, let's say, shouldn't we admit a person with renal? You used to admit them before, you admit them later also. We are not saying that, but we will track whether triage positivity is being assessed well and whether they are being admitted or not. So this simple strategy will bring. And believe me, if you just go based on BMI, if you just do based on BMI, you will find 15% eligible for admission in Chhattisgarh, Jharkhand, because we have the data. I'm sure in many other states in northern India, where the adult undernutrition is higher when compared to southern Indian states. Just based on undernutrition, you'll have to admit 15% of patients. Imagine respiratory insufficiency and inability to stand without support, which indicates poor performance status. That's it. I have lots to share, but we should leave time for other panelists and also for more comments so that we can accordingly discuss. Over to you, Swati.
Absolutely. Thank you so much, Dr. Hemant. So this is really an inspiring project, which actually translated into a nationwide guideline as well. Let's hope that it will be implemented in very good amounts throughout the country. And as mentioned, like I was going through the comments in the chat box, like how much ever we diagnose, how much ever we improve the care in terms of introducing differentiated care, unless we take care of the TB persons with TB who are coming into the purview of healthcare delivery system, unless we strengthen our healthcare delivery system to take care of them, nothing will make sense. So we need to strengthen our healthcare delivery system in general as such. So that sums up our discussion today. We are running short of time. We have already exceeded our committed 7:30. But quick question: if anybody has a question, you can post it on the chat. I had gone through the comments, and many people had suggested multiple things. So Dr. Jishnu had suggested a provision of PDS supplies in terms of nutritional supplementation for persons with TB. Dr. Madhvi, would you like to comment on that possibility of providing a PDS?
Yes, so I think Kerala also has already done that in some sense, diversification. But PDS was one of the things that we had recommended in various fora. If you have to begin how to do it, then probably PDS is one of the important ways through which it can be done. So there is no one size fit all for all states. We'll have to look for various, and it's okay to make some mistakes and modify, delivery mechanisms. That is okay. But PDS can definitely work, especially where stigma is, like where I worked in Jharkhand. Probably PDS is a better option because
Right.
in tribal populations we did not see stigma, but they have more burning problems in their life, so stigma was not the biggest issue over there. But
Right.
that's not the case with most all the regions, so I cannot, it's not one size fit all. There are
Right.
various ways to do it.
Right. And Christianis had a question. I guess it was from Christianis. Maybe Vidit can answer it. Access of sex workers to TB care services, them as a vulnerable population. Have you come across in your experience any insights on that?
Well, yes. So, not me, but a couple of friends work with commercial sex workers systematically, like right there in their health facilities. And what I have learned with from my conversations with them is that largely the issues remain the same that are there with migration and mining and all. Similar living conditions. More stigma to seek out even general care. I mean, let alone TB. They're actually hesitant to even go and buy a cetirizine from a local pharmacy because people know what they do around there. And stigma,
Yes.
I mean, they're a profession which is stigmatized since centuries. And in such a stigmatized profession, you're talking about dealing a disease which is also stigmatized. So it's kind of an exponentially intensified social barrier that they have to deal with. And but what I have heard that the outcome in those population is often worse because often somebody would get diagnosed once they are admitted with severe respiratory distress because the whole time where they could be handled with an ambulatory care was missed, so they directly lined up in an ER and all. And then the often the behavior of the staff with those patients will also not be good. So yeah, these are the challenges that they really face, and the outcomes are horrible. I'm not sure if somebody has documented anything in these populations, but this is what I
Yeah.
know like from my friends.
Right. 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 So also there was this comment from Dr. Vasu. I think Dr. Vasu is in the meeting. She was a speaker last year. That extrapulmonary TB, especially genitourinary TB, is causing a lot of distress, especially among women. So that was one comment from Dr. Vasu. And Mrudula, who is a district program manager of NHM Pune, has commented that involvement of private practitioners, especially Ayush, is very important in TB care. She has commented that. Yeah, so this pretty much sums up our discussion comments today. Any concluding remarks from the speakers? I would take a round of conclusions if anybody has to share anything. Meera?
Yeah. I just concluding my overall, like my message is, my key message is patient voice, like TB voice is really matter, and survival to provide a good platform to share their and to support our health systems.
Thank you, Meera. Vidit?
Yeah, like, I mean, apart from all these expectations of better clinical care and better diagnostics, and what I want to address, like, we should get over this narrative of elimination. TB is not something that we should think of eliminating. We can at best think of controlling and containing it, and then doing the best that we can for those populations who are more at risk of dying. But this elimination, it is really hurting people at all levels, whether it's primary, secondary, or tertiary.
Right. Right. Thank you, Vidit. Dr. Madhvi?
Yeah, I don't have much to add, but I can only say that the issue that I talked about, TB nutrition, undernutrition, is basically, it also gives me an opportunity to think beyond under 5 SAM and mother and child nutrition. Because have you ever seen an undernourished child with having, who has, the family, rest of the family is doing well. So we have to look at a family level.
Right, right.
So, and adult undernutrition is equally important.
Correct. Absolutely. Thank you so much, Dr. Madhvi. Dr. Hemant?
I'd like to share two positive things that have happened. One is the gap between estimated and notified is coming down.
Yes, absolutely.
That is one huge kudos, and a lot of it is to do with private sector engagement.
Correct.
Kudos to that, and we should now focus towards closing the gap further, early detection, and that would happen through more CBNAT, more TrueNAT, have more point of care tests, which will require investments, right? That is number one. Though this was not part of my talk, but number two is about at least there is commitment. So there's commitment for DBT. The money is there. The money is
Yes.
being given. We need to make the right noises. That is it reaching on time? So if the state is releasing the money once a month through bank transfer, so usme already there's an induced delay of 1 month, right? So
Yeah.
these kind of small things, whether it's released every weekly, what's the mechanism? That's where operations and implementation research comes in. We need to make the right noise, and audience that is joining here, any research which is being done to improve the program outcomes is operational research, implementation research. Do simple things. Go to an area, how many had cough, how many were eligible for TB testing, how many got tested, how many went to a health facility, how many had a missed, and work with the health system to do this so that your research contributes to findings. And for differentiated TB care, I am quite clear that we need to go as a public health guidance, triage and treat, and rest leave it on a case to case basis. Everything cannot be done through differentiated
Right.
care. But at least, again, I keep looking at the positives. At least there is a guidance that severity assessment should be done. Before 2021, there was no guidance at all. So we need to, appreciate Central Lead Division for that, right? But we need to then keep making the right noises, for therapeutic nutrition. Where is the data? Where is the data on, for example, differentiated TB care being implemented throughout the country? What's the coverage? How many are undergoing all assessment, right? How many are severely ill? How many are getting admitted? Those who are not getting assessed or not getting comprehensively assessed, are they dying before the assessment because of assessment? I have explained that. So those things we need to keep doing. We need to keep working with the programs, so that we bring some method to madness. I hope I summed it right.
Right.
Bharti, I will just add one more point, because there are
Yes, ma'am.
people here working with patients with tuberculosis. I think it's very important to understand what are the social security schemes available in your region. Map them,
Right.
keep them handy, empower the frontline workers with those available, because I don't think whatever is available is fully utilized also, because we're
Right.
not able to link. So if there is an under five, whether it is linked to, Anganwadi or not, if
Mm.
there's a pregnant mother in the family, whether she's getting what is she's entitled to, even
Right.
post TB death, there is compensation available for transport. It's not being utilized. So I think that mapping and linking is something we should be really working on.
Definitely. Yes, absolutely. So thank you so much, Meera, Vidit, Dr. Madhvi, Dr. Hemant, for spending good 2 hours with us discussing all these key issues. And thank you, Nivarna Christianes, for hosting this particular meeting. And I hope the audience also got some messages, something to take home with this. Christianis, anything which you would like to say?
Yeah, so I just wanted to add one thing, which is that I am currently working in the private sector. So the problem is that private sector health workers are also, we are not very well empowered to treat TB, I feel. Some of the patients that come to me, they have already seen 2, 3 doctors for cough. As soon as somebody says TB testing karana hai, they change doctors. So
Right.
that is also leading to some delay in diagnosis. And then once some patient comes with TB, our seniors in my private setup, I'm saying, they say pulmonologist ko refer kar do, because after you
Mm.
start the anti-TB medication, they will get complications. All of this needs nuanced training, but that is also preventing many patients from accessing care, क्योंकि हर patient तो specialist के पास नहीं जाना चाहिए. This is something that we should be treating at MBBS and post MBBS MD levels.
Right.
So private
Absolutely.
doctor integration into the system is very important, is something I
Very,
feel.
very important. Yes, absolutely. So I think we'll wind up this. Okay, Meera.
I just want to say one thing, Swati and all panelists and all participants here. I'm hoping and with new resolutions in 2026 that this year we hope that we will not face any drug stock out issues, and
Right.
for that we can strongly say and confidently say that TB हारेगा देश जीतेगा.
Absolutely. And for that, our vigilance is very important from the part of community to make sure that the catastrophe which happened 1 year ago does not happen again, because that was really heartbreaking. So let's all hope for the best, and ending it on a positive note, like Dr. Hemant said. So let's all meet soon, some other venue. Thank you so much, everybody, for joining.
Thank
Thank
you.
you.
Yeah.
Bye.
Thank
Thank you.
you.
Thanks, everyone.
Bye.
Bye.
Yeah, bye.
Thanks a lot for joining in.